Hello, this is Dr. Shemen. Today we're going to discuss thyroid diseases, specifically those that pertain to head and neck surgery. The thyroid, as you can see over here, is situated over the portion of the trachea, the windpipe, and the voice box, the larynx. The thyroid produces, understandably, thyroid hormone, which is necessary for every single cell in your body. However, in the mid-1950s, synthetic thyroid or synthroid was created. It was manufactured so that even with removal of the entire thyroid gland, one can function normally if one takes those pills every day. Now, while I say every day, I should point out that your body stores thyroid hormone in your fat. So if you didn't take that medication for a day or so, it's no problem. Now, what are the issues that we face as head and neck surgeons with regards to the thyroid gland? Well, the issue is that the thyroid can enlarge. And if it enlarges like this, it can cause compression of the windpipe and compression of the swallowing pipe, which sits directly behind the thyroid gland. And that then can cause difficulty breathing, or it can cause difficulty swallowing. So in those cases, what we do is we remove that enlarged thyroid gland. The other issue that we face with the thyroid is tumors arising in the thyroid. And here you can see a typical thyroid cancer that arises in one lobe, one portion of the thyroid gland. This one happens to measure about 1.2 centimeters. Now, the way we make the diagnosis of thyroid cancer is that we stick a needle through the patient's neck and get what's called a fine needle aspiration biopsy. And by that means we can determine if that indeed is a cancer or a benign nodule. Now, if it is cancerous or suspicious for being cancerous, what we then do is called a thyroidectomy, which means we remove that portion of the thyroid and we send it down to pathology if we're unsure, or we take out the entire thyroid gland at one sitting and send it down to pathology. If we're unsure as to what it is, we send that half down to the pathologist at the time of the surgery, and the pathologist then examines that tissue to see if it's cancerous. If indeed it is cancerous, then we would proceed to remove the entire thyroid gland. If, on the other hand, they say it's benign or they're not sure, we would end the surgery and wait to get the final pathology, which takes a full week to get the results. And then, if it's cancerous, return the patient to the operating room and remove the remainder of the thyroid gland. Afterwards, if necessary, we can also give radioiodine treatment, which is a single dose treatment to eradicate any spread of the cancer. We also do a neck dissection to clean out any lymph nodes in the neck. Now, the whole issue of thyroid surgery is the fact that the nerve that runs to the voice box sits directly behind the thyroid gland. As you can see over here, it's marked in yellow, and that is running directly into the voice box. So we have to preserve that nerve when we're doing the surgery. In addition, and this is a separate section, we'll talk about the parathyroid glands, but the parathyroid glands are 4 in number, and they are situated on the back portion of the thyroid. And so during the surgery, we also have to protect those structures, and they measure about 2 to 3 millimeters in size, so they're very, very small. And we try to preserve all 4 if possible, or we transplant 1 or 2 at the time of the surgery. Most patients who undergo thyroid surgery can be discharged that same day, and if necessary, we can discharge the patients the next day from the hospital. This is a surgery that I do quite commonly, having done several thousand now in my career, which spans 36 years. And if you have a thyroid nodule, or if you have an enlarged thyroid, which is causing compression, or if you have an overactive thyroid and you're unhappy with the anti-thyroid medications, please feel free to make an appointment by calling us at 212-472-8882. Thank you for your attention.